our first Friday 5 of 2026 here on the Agent Survival Guide podcast. I'm your host, Sarah Ruppel, and this is our weekly list of 5 things you should know about. I hope you had a wonderful holiday break. I spent mine relaxing with family, watching way too much on streaming, so a lot of holiday movies. We wrapped up Alex Rider and Stranger Things, and now we've moved on to The Foundation on Apple TV. I even got a little time to read, so that was nice. And now that I'm enjoying The Foundation, I feel like I might have to pick up some of Isaac Asimov's books for comparison. While all of us were enjoying our holidays and theorizing about the downfall of Vecna, CMS was busy publishing proposals and announcing models that we can actually make a whole episode around that. And I was only out for a little over 2 weeks. We will start out at number 5 with an update on the Rural Health Transformation Program, which I thought we covered in a past Friday 5 episode. But I don't think we talked about it other than in passing around the time when state applications were due. That coverage was super short, just to mention that all 50 states had put in applications for a share of the funding allocation. Quick background on the program. CMS plans to allocate $50 billion over the course of 5 years, awarding a total of $10 billion each year beginning in 2026. Upon application approval, $5 billion will be split equally between all states who put in an application. The other $5 billion, quote, will be awarded to approved states based on individual state metrics and applications that reflect the greatest potential for and scale of impact on the health of rural communities, end quote. Just before the end of 2025, CMS announced that all 50 states would receive funding through the program. For 2026, awards ranged from $147 million on the low end up to $281 million on the higher end. According to CMS admin Dr. Oz, quote, "This program is a historic investment that will catalyze needed change in rural health systems and improve lives for generations to come. For too long, when it comes to healthcare access and infrastructure, we've left behind the backbone of America. That stops now with this program that will spark real change for rural healthcare," end quote. CMS outlined 5 goals of the program in their original release: to support existing and new access points for care, to improve sustainability of those access points, and to develop the rural health workforce while also innovating care and the tech used to deliver it. If you're interested in seeing how much funding was allocated to the states you do business in, we will be linking to that release in the episode notes. Up next at number 4, a new mandatory drug payment model for Medicare Part D, the GUARD model, which stands for Guarding U.S. Medicare Against Rising Drug Costs. According to the CMS proposal, the model would begin on January 1st, 2027 and run for 5 years. During this time, CMS would test using a new formula to calculate rebates for Medicare Part D drugs, specifically the inflation rebate. CMS proposes testing, quote, "an innovative payment model that modifies the inflation rebate for GUARD model drugs using international drug pricing information to identify a benchmark that reflects prices paid in a set of economically comparable countries, which CMS expects would reduce program expenditures for Medicare Part D while preserving or enhancing beneficiaries' quality of care," end quote. During the initial 5-year test, the model would include 25% of beneficiaries enrolled in Medicare Part D plans from, quote, randomly selected geographic areas of the country, end quote. The thinking behind the GARD model is that other countries pay less for their prescription drugs, so why shouldn't we also here in the U.S.? According to the CMS release, quote, Americans pay on average 3 times what other developed countries pay for the same medications, and Medicare Part D drug spending in 2024 made up about 30% of drug spending in the United States, end quote. CMS is accepting public comments on the proposed rule until February 23rd, 2026. We will be linking to more info, including the rule on the Federal Register, which is where you can leave a comment. And we can't talk about prescription drugs without also considering Medicare Part B prescription drugs, which brings us to number 3 on our list, the GLOBE model. GLOBE stands for the Global Benchmark for Efficient Drug Pricing and is another proposed payment model from CMS. Similar to the GARD model, but not quite the same, as it's meant to regulate pricing on, quote, certain separately payable Medicare Part B drugs, which are medications typically administered by physicians in healthcare settings, end quote. So we're looking at some Medicare Part B drugs in this model, and CMS Innovation Center Director Abe Sutton specifically mentioned, quote, GLOBE would help make drugs like life-saving cancer treatments and cutting-edge autoimmune medications available at prices Americans can better afford, end quote. CMS still plans to make changes to the inflation rebate calculation using pricing benchmarks from countries with comparable economic conditions to the U.S. The GLOBE model would start a smidge sooner on October 2026 and also run for a period of 5 years, ending in 2031, just before the start of AEP 2032. Also different from the GARD model, CMS proposes that GLOBE, quote, would apply to Medicare beneficiaries who reside in a defined geographic area encompassing approximately 25% of Medicare beneficiaries in the United States, end quote. The comment period for the GLOBE model proposal is also open until February 23rd, 2026. And we will have links to learn more as well as where to find that proposal in the Federal Register should you want to make a comment. Moving on to number 2, another model, this time a voluntary one, designed to, as CMS says it, quote, expand access to life-changing medicines and promote healthier living, end quote. The BALANCE model aims to do this by giving state Medicaid agencies and Medicare Part D sponsors the ability to cover GLP-1 drugs and also provide them at a lower cost. And because we cannot resist a good acronym, BALANCE stands for the Better Approaches to Lifestyle and Nutrition for Comprehensive Health model. The BALANCE model will allow CMS to negotiate directly with GLP-1 pharmaceutical manufacturers. CMS states that, quote, negotiation areas include guaranteed net pricing and potential out-of-pocket limits for beneficiaries, standardized coverage criteria, and evidence-based lifestyle support offerings, end quote. Historically, insurance coverage of GLP-1 medication, while sometimes prescribed for weight loss, has been limited to use for those with diabetes. The BALANCE model would seek to change that, extending, quote, access to GLP-1s and lifestyle interventions to people with Medicare and Medicaid with obesity or who are overweight to help them improve their health through weight loss, end quote. While improved access to GLP-1s for weight loss is certainly fantastic news, it is important to mention here that the BALANCE model is voluntary, so coverage will depend on a few variables. Drug manufacturers must choose to participate. State Medicaid agencies must choose to participate. Part D plan sponsors must choose to participate. And then from there, and I like the way that CMS puts it, quote, patients would be subject to qualifications set by the negotiations, including certain prior authorization requirements, end quote. So the balance model is not a guarantee of coverage for all individuals. The press release mentioned May 2026 as the earliest target date for the model to launch in Medicaid and a January 2027 start date for Medicare Part D. In the meantime, CMS announced plans to move forward with a new Medicare GLP-1 payment demonstration that is set to launch in July 2026 and carry Medicare beneficiaries over to the start of the balance model in January 2027. The payment demonstration will set pricing for GLP-1 medications at $50 per month for eligible Medicare beneficiaries. Again, important to note that not everyone will be eligible, but eligibility is expanding, which is great news. And then the other interesting part, at least to me, during the payment demonstration, CMS states that, quote, Part D plan sponsors will not carry risk for eligible GLP-1 products furnished under the demonstration, end quote. We will be linking to more info on the balance model in the notes, and we'll also have a post coming soon on our blog, so be on the lookout for that. And that brings us to number 1 on our list today. What might seem like a very small change, but what I see as a super helpful change on the horizon, and a reminder that not all changes have to be big to have meaningful impact. CMS recently proposed changes to how healthcare prices are disclosed to the public, calling for clear, accurate, and actionable healthcare pricing for Americans. So, what does that mean? When asked for comment, CMS admin Dr. Oz had this to say, quote, every person deserves to know what their healthcare will cost without needing a team of analysts to decode it, end quote. This new proposal from the Trump administration aims to build on the 2020 Transparency in Coverage rule. That rule gave us a lot of data, but not always the best experience when trying to interact with it. These are just some of the pain points mentioned in the CMS proposal press release. Quote, oversized files, duplicative data, and information that could not be easily compared across the health insurance landscape has limited its use and reliability, end quote. So CMS has proposed a few suggestions on how to deal with the problem of price transparency in attempts to further cut back on those surprise bills that no one wants to get in the mail. First up, cutting down on waste, removing data for services that are unlikely to be performed from in-network rate files. Next, reorganizing those in-network rate files by provider network instead of by plan, quote, aligning with how most hospitals report data pursuant to the hospital price transparency requirements, end quote. One that surprised me that does not currently exist, a requirement for change log and utilization files, so those viewing the documents are able to see what's changed between versions and to more accurately record what services are being provided. Reducing the frequency of in-network rate reports from monthly to quarterly, which, to be honest, I'm not sure how I feel about that. That might be counterproductive. And then adding more out-of-network pricing information in addition to changing a few different reporting thresholds. I am all for making data easier to compare across the healthcare landscape. I've mentioned it before here on the show, but we love stats. And we especially love when reports are completed annually in similar categories, letting us track changes from year to year. Another thing I want to mention, according to this release, we should be getting a separate proposal for prescription drug disclosure requirements. So that is something else to be on the lookout for. The comment period for this proposed rule is open until February 23rd. So still some time to add a comment there if you like. And we will have the link to do that in the episode notes. Quite a few updates from CMS in the time we have been away. I was hoping to include some fun takeaways from CES prior to getting back into the swing of things, but those will have to wait until next week. If you like what you heard in today's episode, the best way to show your love and make sure you don't miss out on upcoming episodes is to follow along with the show. You can do that where you're listening right now, whether that's on Apple, Spotify, Overcast, or any of the many, many other podcast directories available out there. That will do it for this week's Friday 5. I hope you have a great weekend. Stay healthy and stay safe out there. And we will see you next week. The Agent Survival Guide podcast is a production of Ritter Insurance Marketing, an integrity company. This episode was written and produced by me, Sarah Ruppel. Script editing and fact check by Tina Lamoureux. Podcast design by Urban Rivera. Follow along with our show wherever you like to listen.